Okay, guys, we are back. Ultrasound, YouTube only, ultrasound school. I know I'm repeating myself, but for the sake of the record and the gods who follow up on me, I'm not going to be covering everything in this chapter. This is chapter 19, the pediatric abdomen. A lot of the things are the same exact thing, like Carelli's disease. We've already talked about Carelli's disease. We don't need to talk about it again. If you have it as an adult, you probably had it as an infant. So those, I encourage you to read the entire chapter. I strongly encourage you to read the entire chapter. It's actually not a difficult chapter, not like some of the others that are really hard to read. I think this is a fairly straightforward writing. Probably, yeah, you have different authors in different chapters, and whoever this author was a little more kind, I would say. Other things that I might skip is because we're talking about infants. There are things that we actually talk about in OBGYN, because if you have it, as you could imagine, if you have it as an infant, you probably had it as a fetus as well. And so some of those things I might barely touch. Well, the very first thing I talk about is something that I was going to skip, and I thought, well, I'll just take 30 seconds and talk about it, and then that'll be that. So let's go ahead and start. The first, let me share my screen. The first, nope, I want to share that screen, is coarctation of the aorta. Now, coarctations, 98% of them are in the thorax. So once this baby starts breathing, it's out of our range. We can't see it because it's behind the lungs. Only 2% of coarctations of the aorta are in the abdomen. In fact, I've never even heard of it, or heard of anyone finding it. But in any case, a coarctation is a narrowing of the aorta. This is where we normally would find it. You imagine a heart in here, and as the as the arch is coming around, the coarctation is usually found right about in there. And it has effects on the size of the heart as well. But that's something we're going to talk about next semester. But if you were to see it, well, in the abdomen, I guess, coarctation is a coarctation. It's going to be a narrowing of the aorta. All right, that was my 30 seconds on coarctation. Told you it'd be fast. In general, IVC and aorta, when we're looking at babies, let's look at the situs. Does it make sense? Is the aorta on the left? Is the IVC on the right? They can be perfectly switched over, in which case it would be like a situs inversus totalis, or there could be situs ambiguous going on as well. With situs ambiguous, there could be an interruption. So the IVC kind of comes up and stops, and you have what you end up having is 3 hepatic veins going directly into the heart without an IVC. So that is a possibility. So we just pay attention to those kind of things. Thrombus. Obviously, IVC is a vein. It is typically more susceptible to thrombus, but the aorta is also susceptible, especially with indwelling aortic catheters. So if there's a catheter at all inside the aorta, that can cause thrombus for sure. Tumors of the aorta and IVC, always pay attention to those. The IVC especially, because there are certain childhood tumors of kidney and adrenal gland origin, both of which can take the easiest path, and the easiest path to extend out of these organs is into the renal veins, and then therefore into the IVC. Those are things we just pay attention for. Don't have too much else to say about that right now. like I said, and those renal tumors and adrenal tumors we will talk about next semester. Liver hemangiomas, we've talked about these. What they really are, and normally we see these are kind of small, and small hemangiomas are never a problem. But what they are on a microscopic level are AV malformations, arterial venous malformations. And that, of course, is when your little arteriole, I should say, instead of going through a bed of capillaries, goes straight into a venule. Well, that's a problem overall, because now we have blood flow that is traveling without hindrance from the arteries and into the veins. That's a high volume and high pressure. If you think about it, you lose all that arterial pressure is lost in the capillary bed, and the veins have virtually zero pressure, or very close to zero blood pressure. But in this situation, we now have high volume and high pressure going into that vein, and that can cause some problems. If it's a large AV or large hemangioma with many AV malformations, or if it's a single very large AV malformation. The two subheadings for hemangiomas are hemangioendothelioma and the cavernous hemangioma. Those are the more common that we see in the adult. They are usually echogenic. However, I had a student last semester with 3 large hemangiomas. They were not echogenic. Not only were they not echogenic, they were hypoechoic and heterogeneous. They looked scary. I thought for sure they were not hemangiomas, but they were atypical hemangiomas. So they can have a variable appearance. Let's get a new color here. They may be associated with large skin hemangiomas. So when you see a patient with a large face, neck, shoulder hemangioma, big old red hemangioma, they are associated with liver hemangiomas. So what happens on the skin sometimes actually happens inside of the body as well. So, like I said, if they are large, congestive heart failure, CHF, due to overload of the right heart. The right heart should be receiving blood that is of lower pressure and not necessarily of very high volume, but in congestive heart failure, well, causing congestive heart failure, it's because of the high volume, high pressure blood flow going into the right atrium. If large, they could also rupture, as you could imagine, causing hemoperitoneum or a subcapsular hematoma in the liver as well. They can also, and I'm not sure how, so don't ask. You can't ask anyway, this is recorded. They can cause low platelet count. They can capture platelets. Now, platelets are blood are in the blood. They help coagulate blood when needed, and that's called thrombocytopenia. So that's another thing that a large hemangioma can cause. And the book separated the two, but there was so much, and also I did a little bit of research. There are so many things in common between the two of these. I just included them together. The effects of each are very similar as well. They just have a slightly different cellular makeup. I'm just going to mention mesenchymal hamartoma. They're similar to focal nodular hyperplasia, and I did cross-reference that, and they're not really the same thing, but they kind of have similarities. Focal nodular hyperplasia, we talked about that this semester in the adult. is just an overgrowth of tissue, and mesenchymal hamartoma is an overgrowth of normal tissue as well. And these are benign and can have a mixed appearance. I know I am flying through this, guys. And I'll tell you the truth, I did not finish where I wanted to go with this today, but I realized I have to get down to school and teach half of you in lab. So not quite as far as I wanted to today, but that's okay. We're actually gonna be moving pretty quickly, I think, for the rest of the semester. Not that that's good for you necessarily, but it's good for overall for us in getting things done. Just like adults, infants, children can get hepatitis, mostly viral hepatitis. That can, and other things like a chronic hepatitis, can lead to cirrhosis, even in child. But children probably aren't getting alcoholic cirrhosis, we hope. They can get cirrhosis from biliary atresia. We'll talk about that in a second, but that is what it sounds like. It's a congenital absence of the biliary system or parts of the biliary system. If you can't get that bile out of the liver, it's going to kill it. It's going to cause cirrhosis. Metabolic diseases, Wilson's disease, diseases where the liver is capturing too much copper or too much iron, that can lead to cirrhosis in the child. And cystic fibrosis, that is an overgrowth of very thick mucin. And of course, I'm getting a text. I will answer that one later. Sorry about that interruption, guys. Cystic fibrosis, overgrowth of mucus, mucin, very thick mucin. It can affect the pancreas, which would in turn affect the liver. It can also affect the liver as well. It affects mostly lungs. And the lungs would be the number one. Pancreas, any exocrine organ that produces any kind of mucin is affected by cystic fibrosis, and there's quite a few. Cancer of the liver is rare. Oh, I'll tell you a story though. I was when I was a student in it was a teaching hospital, and it was also a children's hospital, and I did a 7-year-old, about a 7-year-old, did a liver ultrasound, and they had a DNR, a do not resuscitate order on them. Their liver was completely and utterly taken over with cancer. I can't remember if it was a hepatoblastoma, but that is the number one childhood cancer primary cancer of the liver. Or elastoma. Let's put a B in here. Blastoma, hepatoblastoma. There's only about 100 cases a year in the US. So this is rare. You're not going to see this on your first day out, trust me. You might go your entire career never seeing this. And in fact, you probably, even if you worked in a children's hospital, you wouldn't see this very often with only 100 cases a year in the United States. Still, this is the number one cancer. So that tells you that cancer is not unheard of, but thank God it is at least rare. At least liver cancer is rare in the child. It is associated with Beckwith-Weiderman syndrome. That we'll talk about next semester, but this is a overgrowth, a organ overgrowth syndrome. And there's a couple of cancers actually that are associated, childhood cancers, and specifically really toddler and infant cancers are associated with Beckwith-Weiderman. Organ overgrowth, everything from the tongue is too big to fit in the mouth to very large liver and spleen and everything is overgrown. And so it's an overall large child too, but not because of fat, because of organomegaly. Organomegaly, yeah. This particular cancer associated with 2 months to 3 years is average. I think the book said less than 5 years, which is also correct. It's just a different way of looking at it. The appearance would be heterogeneous with indistinct nodular borders. And unfortunately, guys, everything, all these cancers that we're going to talk about, there's only a few, so don't start crying. They're all going to look very similar, and so it'd be very difficult for us to pick any one of them out and say, oh yes, that is HCC and that's hepatoblastoma. They are going to look similar. Although HCC occurs in slightly older children, but that has a similar appearance to hepatoblastoma. So very young, it's probably hepatoblastoma. Older child, it's probably HCC, and HCC is oftentimes associated with long-term cirrhosis, hepatitis, that kind of stuff. So that could help us determine what it is. Of course, a needle biopsy is really the only way to know for sure. What else was I going to say about, oh, and the weird thing about it, so again, this is very rare, thank God. It is rare. And it seems like hepatocellular carcinoma has a spike in childhood, like 10-year-olds, there's a spike there, and then it goes away, and then we live our lives, and then we get older, and it comes back again, and more likely, less rare in the older generation. And my father had HCC, actually. And totally idiopathic, didn't have any that we know of. We don't know why he got it, but he just got it. Mesenchymal sarcoma, again, this appearance is going to be variable, heterogeneous. You know, it creates an actual tumor rather than, it's not so variable that it creates a totally diffuse tumor. But this is the 4th most common primary tumor. So hepatoblastomas are most common hemangioendotheliomas, hepatocellular carcinoma, and then mesenchymal sarcoma. That is the 4th. Any of these tumors, guys, I don't need to go into more detail with them. They are tumors. They're not supposed to be there. And if you guys ever want to take the pediatric registry, then you go back to this book and some other sources and you study them in greater detail. This is just a little section called Children Can Get. They can get portal hypertension. Certainly, if they have cirrhosis, they can get portal hypertension. And we're going to see the same things. You might have reversal of blood flow. You might have caput medusae with the patent umbilical vein. You could have varices, you know, splenic varices, varices of the esophageal varices. So same thing as adults. Portal vein thrombosis can occur as well. So that's a different kind of portal hypertension, of course. That's pre-sinusoidal. Well, portal vein thrombosis, if it's acute, this patient is acutely ill. If it's chronic, then we may have cavernous transformation. So all the little unused or barely used veins in the area from the portal system go up into the liver, bypassing the main portal vein with cavernous transformation. Children can get Budd-Chiari. Remember, that is thrombosis or some kind of mass effect on the hepatic veins. Possibility. And then I put 3 more possibilities of this, this, and this, and that. Just fill in the blanks. They can get it. If we can get it, they can get it. It's more rare, but they can get it. Okay, I said we talked about biliary atresia again. Not seen in the adult unless they had a Kasai procedure. And that's where they would well, it wouldn't be a reattachment, it would be an attachment of the liver, biliary, whatever is left of the biliary system to the duodenum. That's the Kasai procedure. Not seen in the adult because if this person didn't have a Kasai procedure or a liver transplant as a young child, they would not be alive today. So they either, if you see an adult with a liver transplant, it could be because of biliary atresia as a child or as an adult. This occurs in adults as well. Doesn't happen. No, I'm sorry. I just suddenly realized I was thinking of biliary sclerosis. So no, biliary atresia does not ever happen in the adult. That was a mistake by me. Okay. So let's see, adult Kasai procedure, liver transplant. So when we talk about biliary atresia, we could be talking about the absence of the gallbladder only. So that would be a form of biliary atresia. It could be the whole system, in which case I think even the Kasai procedure would not help because the whole system's gone. What are you going to connect to the duodenum? And that patient will need a liver transplant, or the baby will not survive. Or it could just be the common bile duct is missing. And so you're getting a backup into the system, and that would be certainly amendable to the Kasai procedure because you just have to connect the hepatic duct, common hepatic duct, or directly to the bowels. See, now I need a break. In fact, I could do that. Okay, 20-second break because that's all the time I've got. I got to get going here. Sclerosing cholangitis. This is what I meant about adults can get this as well. That was my mistake. Inflammatory disease of bile ducts. I actually was sitting talking to a young woman who had sclerosing cholangitis, and she had just discovered it, and I don't know if she was fully aware that she would eventually need a liver transplant. Thickened walls of ducts, thinned lumens, therefore creating a thin lumen. So when we see our bile duct coming up, and of course it's always kind of thin, but then we see that the walls are just simply thicker, like you really see the walls. Normally we see the walls, but not very well. But suddenly they're looking like this. That can be sclerosing cholangitis. This, of course, can lead to cirrhosis and liver failure. Bam, sorry guys, I know I'm blasting. That's what the book is for. Biliary rhabdomyosarcoma. So the sarcoma is more of a connective tissue. Myo is in smooth muscle. Biliary rhabdomyosarcoma, 1 to 5 years of age. Second most common cause of biliary obstruction. So it is a biliary tumor mass, most likely seen in the liver hilum. So perhaps the common bile duct creates the rhabdomyosarcoma, causes biliary backup. Okay, cystic wait a minute, didn't I already talk about this? I did not. Oh, I mentioned it. Cystic fibrosis and the pancreas. Normally the pancreas in a child is quite hypoechoic or perhaps isoechoic to a healthy liver. And in the adult, we get more echogenic, and that's just normal aging process, whether you abuse your pancreas or not. But an echogenic pancreas in a child, well, if they have cystic fibrosis, that you know it because they've already been diagnosed. But cystic fibrosis can cause an echogenic pancreas. That pancreas is filled with mucin. All the tissues are filled with mucin. The ducts are filled with mucin. That causes a lot of backup, which causes fibrotic tissue, which is also echogenic. And then as tissue dies, it is replaced by fat. So fatty replacement of tissue, and fatty is also echogenic. And of course, this eventually leads to pancreatic failure. It's one of the things that will eventually lead to the death of people with cystic fibrosis. Although I hear they have some pretty spectacular treatments now. Pancreatitis, of course, we think of that as adults, but the number one in the child is blunt trauma, and that could be MVA, or motor vehicle accident. God, they're not calling them accidents anymore because sometimes they're not accidents. It's a stupid thing like that. But blunt trauma, it can also be child abuse. So, if we see pancreatitis in the child, that could actually be an indication of child abuse, but not necessarily. Some of them are just born with bad pancreas. Infections can cause pancreatitis, toxicity to perhaps medicines or something they shouldn't have eaten and they did, or hereditary. Also idiopathic. Sometimes they just don't know where it came from. And then the last thing, I'm going to talk about one big thing today. The last of these speed rounds is in the spleen, sickle cell anemia. That is in the most often in the Black population. In fact, every single sickle cell patient I've ever had has been African American. They can have a huge spleen, and what's happening is all those sickle cells are gathering up in the spleen. Now, sickle cells are not completely and utterly useless. They do still carry oxygen, so having all the blood being captured by the spleen is life-threatening. It actually decreases the overall hematocrit. In other words, the red blood cells. The red blood cells go way down in number, and it could be so bad that in a sickle cell crisis, it could actually kill the patient. Okay. Then there's pyloric stenosis. Here we take our time. Now, I know you guys have seen this a little bit in the video that I already sent. Oh, and I'll post some more videos. I can't post anything right now. Like I said, I'm behind. Firstborn male. Now, is that not weird? Why? Secondborn male? No. But the firstborn, yep. So there's something going on with the firstborn. Now, male-female prevalence, we see that all the time in genetics. So that's not a big, but firstborn, how strange. It's almost like God said, I will take your firstborn. But maybe that's where it comes from, actually. 2 to 10 weeks is really the range. You can't have it before 2 weeks. And even at 2 weeks, most doctors, most radiologists are like, really? But it's possible. I've actually seen it, but it's very rare. 1 to 2 months is the average. If you're going up, if you're at 3 months and a doctor orders it, everyone rolls their eyes because we know it can't be. So it happens in that time period. The babies will have dehydration, projectile vomiting. They say non-bilious, meaning that there's no bile in it because nothing's getting that far. It's basically fluids getting into the stomach and then coming back out. Projectile because the stomach is spazzing, trying to move the fluid into the duodenum where it's supposed to go, and it's really trying very hard, and eventually it goes out the other direction, fires away. Failure to thrive is just an overall catch term for failure to thrive. The baby is not doing well, not gaining weight, looking lethargic. The book says the infant may fast prior to exam, but I'm adding a fluid challenge. That's what we call it. The fluid challenge is a very important part of this exam. Now, what the fluid challenge is you cannot look at an empty stomach and then a pylorus and say, yep, we have pyloric stenosis, because sometimes it just looks thick, but then it's completely dynamic. If it is dynamic, then it is probably not pyloric stenosis. Dynamic meaning, does it open and close? Does it change shape? Does it shorten, lengthen? Does all sorts of crazy things. And it normally is a very dynamic little organ here. And of course, these are muscles, circular muscles going around, and they're able to loosen up and tighten up at the body's will. The fluid challenge is you have the baby drink some water, not milk. It doesn't work well for us, but water, typically sugar water, and we'll fill the stomach with water. And we can even roll the baby onto their right side, which will obviously force more water in the direction of the pylorus. Because remember, the pylorus is the muscle between the stomach and the duodenum. So our duodenum's coming around like this. With this muscle, we look at, well, is it dynamic? Or does it stay in one position and one shape the whole time? Is the thickness of the muscle 4 millimeters or greater? And so that's this measurement from the channel to the outside. Is the length of the channel greater than 1.6 millimeters? And so if it stays in this position and its length is longer than 1.6 millimeters, that too is an indication. Now, when doctors palpate this, when they palpate it, they call it the olive sign. And that's because it feels like and about the size of an olive underneath the skin. Where to find this? Actually, so we know we can follow the stomach. Of course, let's think about what else is here. Let's see. We have duodenum here, which means the pancreas is there, which means the liver is here, and the gallbladder is right about here. So the midline of the body will be about here. So just to the right of midline, at the end of the stomach antrum, or the end of the stomach, which is not always easy to see and understand, but we know it's in this area, medial to the gallbladder and liver, of course. Yeah. Stuff though. Okay. And hopefully your baby is not struggling, crying, screaming, kicking, and doing all of that kind of stuff, because it does make the job a lot harder. I have one more thing written down. It was the last thing on this particular page in my notes, so we'll talk about that. Basor. Basor is undigested material in the GI, typically in the stomach or duodenum perhaps. Inspissated. I always have to say this to myself first. Inspissated. It could be inspissated milk. That's a thickened, really thick milk, or more likely formula. Perhaps they didn't mix the formula very well, or the formula was too thick and it got stuck in there. A phytobasar is plant material, so perhaps we're feeding a kid stuff that we shouldn't be feeding them, or they found something to chew on. And hair, these, both the phytobasal and hair are going to be older, but in the case of hair, sometimes it's just a really bad habit of young women to chew on their hair and they don't even realize they're doing it. But oftentimes they are troubled, mentally retarded, troubled, or perhaps normal IQ, but stressed, distressed, or something. Well, thank God I'm recording. All right. All right, guys. I'm sorry, I don't have a video for you right now, and I know this was a blast through, but I've got to go. And I'll have another one up tomorrow. We'll finish this chapter tomorrow. There's not much left. We'll probably finish this chapter, and I'll probably get the next chapter going as well. So, adios, amigos.